So our next session is understanding recurrence. Oh, I keep hitting the mouse. I'm so sorry. Is understanding recurrence with Dr. Lauren Cobb, who is an associate professor at the Department of Gynecologic Oncology and Reproductive Medicine at the University of Texas MD Anderson Cancer Center here in Houston. She completed her OBGYN residency at Johns Hopkins Hospital and gynecologic oncology fellowships at Duke University. Dr. Cobb leads a comprehensive clinical practice at MD Anderson's location in the Woodlands with a clinical and research focus on the management of low-grade serous ovarian cancer. She serves as the institutional principal investigator for several clinical trials, including studies advancing treatments for this unique cancer subtype. A dedicated educator and advocate, she empowers patients through knowledge and support to navigate their cancer journey with confidence. Please join me in welcoming Dr. Cobb.
So first of all, thank you so much to STAAR for the invitation. It's a real honor and privilege to speak to this group today. You all are wonderful and amazing, so thank you guys for the invitation. As said, my plan today is to talk a bit about recurrence, and I think this may be a little bit of repetition, but I'd like to just give a little bit of a broad overview. I think repetition is never bad, so just to kind of give a big picture, and then just for the sake of big picture, talk a little bit about frontline management, but then really getting pretty quickly into monitoring for recurrence, and then what are our treatment strategies for recurrence if it happens, and putting together hopefully a lot of what's been discussed over the last day and a half into kind of an overall, what do we do? So very basics. This is ovarian cancer in general, so not low grade specifically, but about 19,000 new cases a year in the United States and about 300,000 worldwide. For ovarian cancer in general, again, not low grade, the lifetime risk of developing it is about 1.3%. It's the second most common gynecologic malignancy in the United States, and for ovarian cancer at large, the average age at diagnosis is 63. I'm sure most of you know this, so I'll go through this quickly. But there are several categories of ovarian cancer, and kind of depending upon where the cells originate from in the ovary. So epithelial ovarian cancer really refers mostly to sort of this outer lining, and really, as we've learned more and more about ovarian cancer, probably somewhat from the fallopian tube as well. And so within this epithelial type of ovarian cancer, we have serous, mucinous, endometrioid, clear cell, transitional cell. Those are kind of the biggest categories. And so within that, within serous, we have both high-grade serous and low-grade serous. So as you all know, that is what we're talking about today, is this low-grade serous category. And so as you all know, low-grade serous ovarian cancer was quite rare. So serous carcinoma in general, so that sort of bigger category is the most common type of our epithelial ovarian cancers. It's about 60 to 70%. And low-grade is about 5% of that, so quite rare. And I gave the stats for high grade, but low grade really is characterized by a much younger age on average, so closer to 45 at diagnosis. It seems to be somewhat chemo-resistant, so it doesn't respond quite as well to what we give ovarian cancer at large, and does have a longer survival, as people have alluded to today, as compared to high-grade serous ovarian cancer. And so I suspect others may have kind of talked about this, but as a little background, it used to be that ovarian cancer grade, meaning how aggressive or scary do those cells look under the microscope, was grade 1, 2, and 3, 1 being sort of the least scary looking, maybe growing the most slowly, to grade 3 being sort of the opposite of that, most aggressive behaving and scariest looking under the microscope. And over time, this has sort of changed to really more binary. Low grade, high grade, as opposed to sort of 1, 2, 3. And these are the definitions for how that was decided at the pathology level, but it has to do with how abnormal those nuclei look and how much it looks like they're dividing. And a lot of that work was done at MD Anderson many years ago. So again, just to kind of review initially, when you are getting diagnosed, you have baseline labs. Tumor markers are done. Often CA-125 is probably the most important, but there are others, and a CT scan. And it may say things like ascites, which is the fluid that can sometimes form in the abdomen when you have kind of cancer speckled through there. Omental caking, that means sort of a thickening of the omentum, the fat pad that hangs from your colon, or carcinomatosis, so those little speckles of disease that can kind of land in various places. And so that's part of your initial workup. The stages that I know you guys are all familiar with, and this, I'll just kind of go through this quickly, but stage 1 is really confined to both ovary, or one or both ovaries. Stage 2 may have sort of spread a little bit into the pelvis, but not beyond that. Stage 3 is more kind of full abdomen, so maybe there's something outside of the pelvis in the omentum or elsewhere. And then stage 4 is really, is it inside the liver, in the lung, or sort of outside the abdominal cavity as well? And so, you know, most ovarian cancers at large, and including low grades, are diagnosed at this stage 3 and 4. It's typically staged surgically, meaning, and a combination of imaging as well if it's really clear. But often we determine what somebody's stage is as part of their sort of upfront surgery. And like I just said, about 70 to 80% of patients have stage 2 to 4 at the time of diagnosis. And so upfront, you know, you may have had a pelvic mass, something like that, and you're gonna go for a surgery. So the first question is it confined to an ovary? If you look at the CT scan and you think, this person has a pelvic mass, I don't know what it is, I don't see anything else, you might have what's called a staging surgery. So that ovary's removed, potentially the other ovary, depending on what's happening, the uterus, the omentum, and some lymph nodes to really see, you know, where has that cancer gone. I don't see anything else, but I want to know if there's microscopic or small volume something elsewhere. But if you get that scan and you see that there's disease outside of that pelvic mass, then really what you're talking about is a debulking surgery where you are removing the bulk of what you see. Frontline management, so surgery alone is really only what happens for sort of the very earliest stages of ovarian cancer. So stage 1A, or sorry, for low-grade serous ovarian cancer, really stage 1A or 1B, so now I'm kind of flipping to the low-grade part. And then, but really contemporary multimodal therapy is important, and for most patients end up getting both surgery and some sort of systemic therapy, and we'll talk about what that is in a second. So again, this is your early stage kind of slide. You have a pelvic mass, you don't know what it is. We don't usually just biopsy pelvic masses if we think they're isolated. You go in, you have a surgery. While we're still operating, we send it to pathology. They take a look at it under the microscope, and they say, we think it's cancer, we don't think it's cancer, or maybe it's somewhere in between, and I won't get into that today, but that's more of like a borderline tumor. And then based on what they say, then we do sort of that series of events that I mentioned, take the other ovary, the uterus, the omentum, lymph nodes if we think that there's cancer involved, or open if we actually see something else that needs to be debulked. And then following that, people standardly will get carboplatin and Taxol for 6 cycles, as you all are well aware, and then maintenance letrozole. Advanced stage disease is very similar, but again, it depends somewhat on whether the disease is felt to be resectable or not. If it's felt to be unresectable, then we do give what's called neoadjuvant chemotherapy with usually 3 cycles, although sometimes there is room for more depending on what's happening. People will have an interval surgery, meaning they've got a little chemo to hopefully shrink things and then get a little more chemo after the surgery that happens, followed by maintenance letrozole. But if we think it's resectable, like I just mentioned, then you would have your surgery, whatever that looks like, followed by the chemo and the maintenance letrozole. I will say for low-grade patients, and we'll get into this in a little bit, as I'm sure you've heard over the last couple days, it does seem to be more resistant to that chemotherapy. And so we really try and resect when we can up front, because we know that sometimes that chemotherapy may not work quite as well as we would like it to. But sometimes we have to give chemotherapy, depending on somebody's other medical issues or, you know, the spread of disease, things like that. And then maintenance hormonal therapy, you know, I mentioned that in the 2 prior slides, but up front, pretty standardly at MD Anderson, we are giving, you know, all of our patients in the maintenance setting, meaning they finished their carboplatin and their Taxol, and now they're ready to move on to kind of a maintenance phase. We do give letrozole. And this was based on a study by Dr. Gershenson. It wasn't a trial, so patients weren't sort of randomized to get it or not, but it was more retrospective, meaning kind of a look back at patients who got it and see what happened to them. And so of all of the patients that got had sort of an upfront surgery followed by chemotherapy, the ones that had hormonal maintenance did seem to do much better than those that were just observed, and these are some of those numbers. PFS in this setting is progression-free survival, meaning from the point that you finish your treatment to the point that it comes back. That's your sort of progression-free survival. And it was much longer for the patients that got the hormone maintenance, so 65 months versus 26 months. Although that point that Dr. Grisham was mentioning, overall survival didn't seem to be that different between the two. And then when you look at actually the subgroups, so patients who had chemotherapy, had their surgery, had chemotherapy, and were disease-free in their scan or at the end of surgery, did even better, and had more of an 81-month progression-free survival rate versus 30 months. People that had more persistent disease that was present, still some benefit, but maybe not quite as drastic. And so based on that, we do, like I said, give maintenance letrozole to all our patients, but I don't think that's necessarily universal across the board. I just wanted to touch on this a little bit. I know I get a lot of questions in clinic about BRCA and whether that's relevant and low grade, and it is a recommendation to get genetic testing for all patients with ovarian cancer, but I'll say that it does seem to be a much rarer finding in patients with low grade. So this was a study done by Dr. Norquist, who's at the University of Washington, and they took a bunch of patients from trials that had been done and through their tissue banking collection system and did genetic testing on all of them and really found that of the, I think, 1,900 patients that they looked at, really very few, 66 of them had low grade and only 4 of those had BRCA mutations, so relatively rare. Still worth looking for, but relatively rare. Okay, so we've gotten through upfront kind of summary, so thank you for bearing with me in that summary. So what do we do now? So you're done with your chemotherapy. Now hopefully you're on your letrozole maintenance. And typically this varies by institution, so there's no 100% right or wrong way to do it, but in our practice typically we'll follow patients every 3 months for the first couple of years. We'll then spread it out to every 6 months for the 3 years after that, and then annually. CA-125, which I'll get to in a second, is a tumor marker, as you all know, for ovarian cancer. And we, as an institution, do check it at each of these time points, but there are some limitations to that, which I'll mention in a second. These visits usually also include a symptom review, and imaging is sort of somewhat dependent. So, and I'll get to that in a second, actually, so I'll come back to that. So CA-125, you get your CA-125s, I'm sure you're all very familiar with this. It has what's called a high sensitivity, but a low specificity, meaning, it can be quite elevated in things that are not ovarian cancer. So it's not particularly specific. Now, patients with quite a bit of ovarian cancer, it's usually going to be a little bit elevated, but that's not always true. So the 4th point down there, especially patients with low grade, it's not always a great marker for you. Some of you may find that it has been, but you may find that it's not. There's a few other types of epithelial ovarian cancer that doesn't always do a great job either, mucinous and clear cell. So while I think it is a helpful marker and something that we check just as an added piece of information, I really try and encourage patients not to sort of hang everything on that number because it can mean so many things. It can mean that cancer is starting to grow, but it can also mean you have an infection. I have a number of patients who had COVID or a bronchitis or a GI bug or something else that makes it go up. Diverticulitis recently just happened to one of my patients, and then it comes back down. So not to provide necessarily a sense of false hope, but I think that we just have to be very mindful when we get that number back. And it's also not quite as helpful in small volume disease. If you have just a little bit that you're kind of following, it may still continue to be normal. And then really the other big picture is that CA-125 measurements kind of over time haven't been associated with that thing we care about, right, the overall survival number. Again, we still do it, but it's not a perfect test by any means. We do check symptoms with patients. Obviously, this is going to be sort of a big indicator that we need sooner imaging than we'd planned to if we hadn't planned any. And it's the same as what you think about up front. So you're bloating, abdominal pain or pelvic pain, difficulty eating or feeling full quickly, sometimes urinary symptoms if it comes back kind of in the pelvis specifically, and any of these symptoms being sort of new onset, frequent, or persistent. And so, actually, just to go back, I said I'd talk a little bit again about imaging. I think there's probably a variety of practice patterns in how imaging is handled. In ovarian cancer in general, it's not necessarily recommended to do routine imaging every 3 months or 6 months, whatever it may be, because it hasn't been necessarily shown to change, again, that thing that we think about, that overall survival. But there was a group of sort of experts in low grade that got together and kind of made some consensus guidelines. And in that group, they did suggest that there probably is some benefit, actually, because CA-125 is not great for low grade, that maybe we should be getting more interval imaging. So I'm throwing that out there. I'm not saying that your provider should or shouldn't, and certainly that's a decision between you and your doctors, but just something to think about, that it may be a little more relevant in patients with low grade than patients who have high grade. But I think, as for those of you that were just in the thriving session, fear of recurrence is real, and it's hard for me to get up here and talk about how you feel. I'm not the one with cancer, but I think it is. I understand, that it is hard. It's hard to sit there and see your number do this or that, and not know what's happening, and know that it could be a long time. And so I think remembering, one, that you have this amazing group of people, but hopefully other support systems in place as well. And this is amazing. You guys should get each other's numbers if you haven't already, and stay in contact, because support systems are really, really important. Be kind to yourself. I think everybody is different in terms of what they want to know. I'm personally quite, hopefully my patients would agree, but very honest in clinic about what I think and where things are going and what's happening. But not everybody wants to hear everything, and can cause a lot of anxiety. So I think know yourself and know what you do and don't want to know, and communicate that with your loved ones and your provider. I think they talked about this in the last session, but developing new hobbies or skills, or thriving rather than just surviving, is important. And remembering that there are things that you can't control. If the disease is going to come back, if so, when. Try to, again, it's easy for me to say this, but try to avoid dwelling on things like that. Really engaging in self-care, whatever that means to you. And then seeking support from those you trust, controlling what you can, and then if you need professional help, there's no shame in that by any means. I think, it's very understandable why someone might want or need to speak with, a professional as they go through this and are dealing with the thoughts about recurrence. So then what next? So what if recurrence is suspected or confirmed? So sometimes there's a role for doing a biopsy. I think if it's quite clear, and again, there's a lot of nuance to all of this, again, with your provider, but sometimes it's not clear, and so sometimes a biopsy is needed. But I do want to kind of reemphasize that low grade is a slow-growing process, and patients with low grade do survive much longer than patients with high grade. So, I try and encourage patients to, hopefully not jump off of whatever we're doing immediately in a rush, because what we may do next may be a lot more toxic than whatever you're on, and it's a marathon, not a race, and we want to sort of be very thoughtful about how miserable we're making you with treatment versus what is the cancer doing. And if we want to just kind of really think about that individually with each person that we're treating. With low grade, I think the real goal with our research and what's happening kind of through time is finding things that can be tolerated for a long time, because you do live so long, right? So chemotherapy, even if there are responses, is not something you can just be on forever. Your bone marrow won't tolerate it, and it's just hard on your body. So I think that's really on us. We need to continue to do the work that's happening and figuring out how, what can we do to continue to move the science forward, to find tolerable treatment that will really, do a good job for a while. And then, like I said, kind of to reiterate all of this, in some patients it can really behave like a chronic condition. I have patients who were diagnosed in the 90s. They're still here with us, you know. So I think that's not necessarily true for everybody, but keeping that in mind, it can really be like that. And again, treatment decisions are individual, so I'll just put that caveat out there again. Anything that I say today, you really need to obviously discuss with your doctor because everybody's unique situation is unique. And so I think this slide is has a lot of options listed on it. I'll kind of go through them one by one. But I think what's hopeful about it is we didn't used to always have all of these things that to even list, right? I mean, this almost fills the page, which I think is quite amazing. And so I'll kind of go through these one by one. And some of this, again, may be a little bit repetitive from what you've heard before. I think the first question I often get is, can you just take it out again? And sometimes, you know, a lot of our data, as you know, is in high-grade serous patients. It's more common, and that's what we have a lot of data in. And in high-grade serous patients, the data is mixed. But it does show some possible benefit in certain groups of people. You know, has it been a long time since you last had treatment? Is that treatment-free interval long, meaning that if we kind of get you to disease-free again, is that going to give you some benefit, or is it worth the risk of surgery and the complications that may come from it? Is the disease really isolated, or is it more spread? Is there ascites, you know, that fluid that can, even if you don't see the disease behind it, there probably is a little bit that's making that fluid, right? Or where is the tumor located? Is it resectable? Is complete removal of it possible? And so these are some of the things that were looked at least in the high-grade serous population. But unfortunately, a lot of the studies that were done just have very few low-grade serous patients in them. So we really rely a lot on kind of experience as well as retrospective studies, again, that kind of look back at what you do with people and how it goes. Again, not randomized, but a look back. And there have been some studies that show that perhaps low-grade patients do benefit intermittently from surgery if it can be completely resected, and again, follow some of these same thoughts. But again, that's very individualized, and discussion with your physician is key. So I'll throw that out there one more time. So surgery doesn't always necessarily make sense. And so as I alluded to, and others have, you know, this cancer can be quite chemo-resistant, and even if it does respond, again, chemo is something that's hard to be on kind of indefinitely or intermittently. And so this is some of I'll kind of show this in a second, some of the response rates to chemotherapy. But they are quite low, both in the neoadjuvant, meaning that setting where you get chemo and then you have your upfront surgery, so that's the neoadjuvant setting, and then in the recurrent setting. So we did a study at MD Anderson where we looked back at patients who, with low-grade serous ovarian cancer who had neoadjuvant chemotherapy, and basically cross-compared it to a similar group of patients in a different database that we have that we kind of matched based on their characteristics with patients with high grade to really get a sense of how are patients doing, what's the difference. And I don't know if people have gone through how to read a waterfall plot with you, but when disease shrinks, it's on the bars go down from the zero. That zero is that kind of middle line, and when the disease grows, it grows up. And so you want to look like the bar graph on the right, the high-grade serous, where you see all of that blue. You want the disease to shrink. But what we found with neoadjuvant chemotherapy is it really looks a lot more like the left. And those blue bars are the patients that had true responses. And so what that means to us is whatever they're measuring is at least 30% smaller than it was. So it's very kind of technical in trials, what we define as response. But that's what response means to us. And so it's just obviously much fewer than we would like to see. And this is seen also in recurrent disease as well. Dr. Gershenson did a study back in 2009, again, retrospective, looking back at groups of patients that had chemotherapy and a number of different regimens. And, one of the 108 regimens that they looked at had a complete response. 3 had a partial response, and so that overall response rate, again, everybody that had at least 30% or better, was only about 4%. And that was better, a little bit closer to 5% for people who had been a while since they'd had a platinum-containing drug, so we consider that platinum sensitive, but even less so if they either grew on the carboplatin. So not super exciting. Now, a number of patients had stable disease, but again, with something that's so toxic, I don't think that's good enough, and I think you'd probably agree we need something better than that. I think bevacizumab is an important kind of additive, particularly in low-grade patients. So Dr. Grisham just got off the stage, but she did a nice study back in 2014 looking at patients who, most of these actually, the bevacizumab was in combination with chemotherapy, but the response rates were actually much higher when you added this bevacizumab, and a couple of these patients had Avastin alone. And this was seen also in a study done at MD Anderson. Dr. Dalton was at MD Anderson at the time. And similarly, responses were pretty good, so closer to 40% with the Avastin. So again, I have patients I've treated with Avastin alone for quite a while as an option. And so I think that's not to be forgotten too as a viable thing to think about. And so as studies are happening for low-grade serous ovarian cancer, we borrow a lot from breast cancer. I think Dr. Slomovitz may have talked about this somewhat yesterday. What we've seen is that series have shown that at least 80% of low-grade serous ovarian cancers are estrogen receptor positive, as many ovarian cancer patients are. Low-grade responds to sort of anti-estrogen hormonal therapy. And again, 9% doesn't sound amazing, but I'll kind of get to why we don't hate that in a second, but in the recurrent setting, it is quite tolerable usually. And then, again, borrowing from breast cancer, following primary surgery and chemo, hormonal maintenance does seem to benefit patients with breast cancer, again, as it has sort of with our patients with low-grade. And even that, monotherapy appears promising. I didn't get into sort of the upfront trials that are happening. Hopefully somebody did, but there is a trial that's currently ongoing that's still enrolling. I think it'll close in May. That's in that upfront setting, looking at chemotherapy followed by letrozole maintenance versus just letrozole maintenance and kind of forgetting about chemotherapy altogether. So that question hopefully will be answered in the next couple of years. But I think it'll stop enrolling in May is what I heard. So what hormonal therapies might we use? I think the aromatase inhibitors are some of the most popular and effective. Letrozole is kind of the most common that people will get up front, although anastrozole and exemestane are also options. Just as a little bit of a mechanism talk, so aromatase inhibitors, in case y'all aren't familiar with how they work, they basically block the formation of estrogen kind of at the level of your fat cells. So your fat cells have this enzyme in them called aromatase, and that converts this sort of steroid pre-estrogen that your adrenal gland makes into estrogen. And so you kind of block it at that level. So even if your ovaries are gone and you don't have that making estrogen anymore, it kind of knocks out any last, as best it can, last estrogen that you may have floating around from that. And then other options would be a selective estrogen receptor degrader, so it more acts at the level of the receptor on the cells, and then a receptor modulator, which is tamoxifen. And so these are some of the studies that have looked at hormonal therapy, and the response rates are pretty consistent across the board, probably about 9%, although a little bit better with letrozole or these aromatase inhibitors, probably closer to 13%. Again, Dr. Gershenson, who's done many of the studies in this space, looked at patients who had a number of different hormonal-based regimens. And when you looked at just the patients that got aromatase inhibitors, that's that kind of, I didn't highlight it in red, but it's right underneath that first line, is about 13%. But in combination with sort of all the hormonal options, it was more like 9%. Tamoxifen didn't seem to do quite as well as we hoped in any of the studies that we looked at. It was about 6% in this one that he did, but it was 0% in this clinical trial that's listed next, GOG 281, which I'll get to that trial in a few slides. And then the Paragon study looked at a different aromatase inhibitor. It was anastrozole, and again, it was pretty similar to the letrozole in terms of responses, but about 13% of patients responded. So again, I think we think that 13% doesn't sound great, but I think one thing to keep in mind is that there's still quite a high clinical benefit, meaning it can keep disease stable, and it's something you can be on for years and years. And I know I have people that hate their letrozole, so I'm not trying to say that it's a drug that makes you feel well. I know you don't. But when we compare it to things like chemotherapy, I think it certainly is more tolerable than that. Hopefully you feel the same way. But borrowing again from breast cancer, there's a lot of rationale for maybe combining this estrogen or hormonal-based therapy or hormone blocker with something called a CDK4/6 inhibitor. And so, this slide gets a little technical, but I think the point of it is, on the right side of the slide is really kind of the process of cell division and cell growth. And estrogen really stimulates part of that process that requires sort of a binding with CDK4/6. And so if you can kind of block it at both levels, block the estrogen and block the CDK4/6, maybe you can kind of have an additive effect and even potentially benefit patients who may have been otherwise resistant to the hormone therapy alone. So the problem is that we don't have enough data to say that patients who don't have, maybe are you talking about like who don't have estrogen receptor positivity on their, some patients don't necessarily have a lot of estrogen receptor positivity, although most do, but we haven't seen we don't know. So that's being looked into, but we don't know. It's a good question though. So this slide is hard to read, but really just emphasizing all of the studies that have been done in breast cancer with this combination of CDK4/6 inhibition with the endocrine or anti-hormonal therapy. And all of them, when they do this combination, really benefits patient survival over the endocrine therapy alone. And these are randomized trials in breast cancer. So that's why we're really borrowing from what we've learned from breast and maybe think, could we do this in low-grade serous ovarian cancer? And so Dr. Slimovitz, who spoke yesterday, hopefully he presented his own study, but this is ribociclib with letrozole. So again, the CDK4/6 inhibitor here is the ribociclib in combination with letrozole in patients with recurrent low-grade. And you can see, again, here we have another waterfall plot. So there's quite a few blue bars, which is good. At the point that this was presented at our big annual meeting in 2023, the response rate was about 23%, which is better than 13%. I think he is hopeful that once they get all the final data analyzed and everybody's through follow-up, I think my suspicion is it'll be higher than that and that, patients were still kind of going through at that analysis time. But a really high clinical benefit rate. And I don't think I said what that was before, but a clinical benefit rate is both the response and stable disease mixed together. So maybe it doesn't shrink much, but it stays stable. And so the clinical benefit rate with this combination was almost 80%. And it took about 8 months for patients to see a response that did. Actually, and I'll go back. And I think even better is that the duration of response was about 20 months or 19 months, which is good. And so I think that strategy that I just mentioned is an important one. It's one that as things work, and as Dr. Grisham mentioned, as things work in the recurrent setting, we want to bring them to the front line. We did a study at MD Anderson in the neoadjuvant setting with a combination of CDK4/6 inhibitor. I didn't make a slide about it because, again, I'm supposed to focus on recurrence. But we did do a study looking at abemaciclib, which is another CDK4/6 inhibitor, with fulvestrant, which is a sort of anti-hormonal agent in the neoadjuvant setting, with quite promising results. So that paper should be forthcoming. But we presented it a couple years ago, and the responses to that in that very small group of 15 patients were about 60%, which is amazing. So kind of moving on to a different strategy. So many patients with low-grade serous ovarian cancer have some sort of mutation in this particular pathway. And so this is a very simplified slide. It doesn't go kind of one-to-one like this, but I think it's an easier sort of pictorial representation of potentially what's happening. And so I'll kind of come back to this study or this slide in a second, but the RAS pathway or the MAP kinase pathway involves mutation or proteins called BRAF, MEK, ERK, and all of sort of mutations in this pathway can lead to sort of a upregulation in cell growth, which is kind of what this is supposed to say. And so, RAS pathway mutations are relatively common in low-grade serous ovarian cancer. So BRAF, not quite as common, but about 5 to 10%. KRAS, a little more common at 20 to 40%, and NRAS at 9 to 26. And so first wanted to talk about trametinib, which blocks sort of this MEK part of the pathway. I don't know if any of you have received a MEK inhibitor. Trametinib is kind of the most popular right now, but there are others that have been studied over time. And I don't have slides on those, but there was some activity in selumetinib as well, or binimetinib as well, which were prior studies that were done. But the most, I think, promising one was trametinib, and this was a big study that was done of 260 patients, and it randomized patients to either receive trametinib or what was considered standard of care by physician's choice, and that included whatever they decided to put the patient on, kind of based on their history, but could include letrozole, pegylated liposomal doxorubicin, Taxol, tamoxifen, or topotecan. There was crossover allowed in this study, as I think Dr. Grisham went through what that means. And I assume that people have maybe talked through a little bit of what survival curves look like, but on the sort of y-axis, you're looking at percentage alive and progression-free, and on the x-axis is time. And so you want your curve to be as horizontal and up at the top as possible. And so in that, the red line is more favorable than the blue line. And so in the A, we're comparing trametinib with just standard of care at large, and the patients with trametinib did a little bit better. The overall response rate was about 26% versus the standard of care was 6.2%. And then the progression-free survival in that sort of top A survival curve was 13 months versus 7.2 months for standard of care. That B survival curve is actually pulling out the letrozole patients specifically, and still seems to do better than letrozole, with 15 months progression-free survival versus 10. So trametinib has become now an option in the standard of care setting for us because of that data that was published. And so now kind of moving up a little bit on our pathway, BRAF, while not as common as KRAS mutations, there are drugs that target that. And so there was this study that was sort of pan-tumor, so not just ovarian cancer, but other tumor types as well, that looked at the combination of both a BRAF inhibitor and a MEK inhibitor. So it was dabrafenib and trametinib together in patients with a very specific BRAF mutation. And so this slide includes, all of the patients with a number of different types of cancers, but the dark teal are the ovarian cancers, or GYN cancers, and 5 patients had low grade. So it doesn't sound like a lot, but it's worth noting. 4 out of the 5 of them had a partial response. 1 out of 5 had stable disease, and of those 2 of those partial responses lasted at least 2 years. 1 lasted 12 months, and the 4th was still kind of being evaluated, hadn't progressed yet, but at the time the study was kind of analyzed, was still progression-free at 10 months. So that's, I think, a real option for patients. And based on sort of the overall data from this study, the FDA granted approval for dabrafenib and trametinib together for any patients with an unresectable or metastatic solid tumor across the board, so including you guys with this particular mutation. So hopefully your providers will keep that in mind if you have it. I won't go into this too much because I know Dr. Grisham is certainly the expert in this particular study, as she's the principal investigator for it. But this also gets at that same pathway. And the 2 drugs that it looks at, one is avutametinib, which kind of blocks both the RAF and the MEK simultaneously, so it's called a RAF-MEK clamp, and also targets this sort of parallel pathway that if the tumor learns how to kind of escape from that, maybe you can also block this thing called FAK. So this sort of dual blockade of both hopefully will provide more more success. And so they're both oral drugs, and I think that's all I was going to say on this slide. And again, I know Dr. Grisham just went through all of this, so I won't go through it in too much detail. But really, the phase 2 study was RAMP 201. I think I heard somebody in the room say they were on this study. Was both of you guys? Great. So the part A of it was really to determine sort of which, what is the go forward? Is it going to be the avutametinib or the combination of avutametinib and defactinib? And so what went forward was the combination, and so and that was expanded. And so the part A, B, and C were all presented recently at an international conference in Ireland that we went to. And I think the response rates were quite impressive, especially in the recurrent setting. So it was 31, and this is in those sort of blue, very top box, 31% overall But in the patients with KRAS mutations was 44%. And I think Dr. Grisham probably mentioned that's what's sort of going forward as hopefully an accelerated approval to the FDA. But I think the goal is hopefully to have it approved for everybody, because 17% in a KRAS wild type, that's still, while doesn't sound amazing, is may be better than some other responses that they may have to other things, certainly to chemotherapy, and maybe on par with some of the hormonal agents, if not a little better. So we want patients to have access to everything they can have access to. And really, I think what's also exciting is that patients had responses even when they had a prior MEK inhibitor. So if they had trametinib before, they still had responses. And so you can see kind of just under that line, 24% with prior MEK inhibitor did have responses, which is, again, good. The median time to response was about 3.7 months, and the duration of response, sort of median, was 31 months, which is great. So this is very exciting, and she went into the Chameleon study, which is moving this to the evaluation in the front line, but I think we're all really excited to see what happens with this. We have the phase 3 study open at MD Anderson as well, which is RAMP 301. So it's now taking that combination into the randomized setting. And again, I know Dr. Grisham just went through this, but it's randomizing patients to either the combination versus investigator's choice. And the most recent version of this protocol does now allow for prior MEK inhibition, and the 4 drugs that are now kind of included in physician's choice are the pegylated liposomal doxorubicin, paclitaxel, letrozole, and anastrozole. So excited to see what happens with this study. I wanted to bring sort of one other sort of idea into play, and this is, I don't know how many of you have heard of PARP inhibitors, but PARP inhibitors are very kind of latest and greatest idea for ovarian cancer in general, but particularly high-grade serous patients who have mutations in BRCA or BRCA-like, either themselves or in their tumors. And it's been shown that patients with KRAS mutations seem to be pretty resistant to PARP inhibitors. They haven't been very helpful. And so the thought was that maybe if you have a KRAS inhibitor, maybe you would be less resistant to PARP. And so this was a phase 1 study, just kind of looking at overall safety and a little bit of efficacy and sort of a pan tumor. Their cholangiocarcinomas were included, lung, rectal, to see if it's tolerable and if there's any kind of signal to move it forward. The green bars are ovarian cancer, and so you can see actually there were some responses that kind of spurred things to move forward a little bit. And so there was an expansion phase of this in RAS aberrant ovarian cancer, and as you might suspect, that did include several low-grade serous ovarian cancer patients, and this was presented by Dr. Weston at our kind of big annual meeting in 2023. And of the low-grade patients, so that last little section there, again, only 9 patients had low-grade that were in this group of the 19, but 44% of them, so 4, had a partial response, and then 3 additional had stable disease. So again, and some of these responses were quite long and durable, so you see those long sort of purple bars, which is good. That's what you want to see. And so you can see LGSOC, those are patients with low grade. So I think, this is still in the trial setting and has actually moved forward to something called the combo match trial. I don't know if any of you are involved with that or have been treated on that. It is still enrolling. It's for patients with both RAS mutant ovarian, and there's a cohort for endometrial cancer as well who have RAS mutations. And it's looking at selumetinib, which is a different MEK inhibitor with or without olaparib. So one arm gets the selumetinib alone, and one gets the selumetinib with the olaparib. So kind of interested to see what happens with this study as well. I don't remember if Dr. Grisham mentioned mirvetuximab. I think this is data for high-grade serous ovarian cancer. So this is a study that was done in platinum-resistant high-grade serous ovarian cancer. Platinum-resistant, again, means that they received a platinum but have progressed within 6 months of their last dose of it. And in that group of patients, they saw response rates of 42% to this drug, this mirvetuximab, versus 15% to the chemo. So it really did a good job in this group of patients. Now, what's important to know about mirvetuximab is that it's what's called an antibody-drug conjugate. And I don't know if anybody's gotten into this at all in this setting. An antibody-drug conjugate is a new class of drug that's, I think a lot of other disease sites are farther along than we probably are in GYN, but we're picking up, and there are several that are approved in the GYN space. And basically it works by, it's an antibody, and it binds to something on the outside of the cell. It's kind of engulfed by the cell, so this is what the picture on the bottom shows. And then a bunch of kind of things that help the cell die are released, and then the cell dies. And I think that's sometimes how people think chemo works, but it actually doesn't work that way. And this is a very specific kind of mechanism for how this drug and others like it work. And so, this study was done in high-grade serous ovarian patients. That was an eligibility criteria, so there were no low-grade patients in this study. But ultimately, the FDA approved it for any folate receptor positive, platinum-resistant epithelial ovarian cancer, so that includes low-grade patients. And I should say that the thing that antibody binds to make this particular drug work is folate receptor. So you have to have enough of it on your cells for that drug to make sense. And what the kind of test that was done is 75% is what was kind of deemed to be positive. But if you have positivity, folate receptor positivity, this may be an option for you. We're starting to collect kind of anecdotally patients that have received it that it may be helpful for. We don't know yet. There's not a study yet. I think that's being talked about. But it is something that you could get because there is an FDA approval for it. And I think it would be worth exploring if you fall into that category of having folate receptor positivity. And so these are the NCCN guidelines for recurrent low-grade, and they're missing a lot of the things that I mentioned. So the NCCN, it's kind of what the experts in nationally have kind of gotten together and decided, based on the science we have, this is what we think is reasonable to give. And the NCCN guidelines give a lot more than just this. It's pages and pages and pages of what you do when, surgery, chemo, all that sort of stuff. And so I pulled this out of the recurrent page for low-grade serous, but these are sort of the guideline compendium-listed drugs. And so you can see the dabrafenib and trametinib, you can see the trametinib, the hormonal therapy, chemotherapy if not previously used, or observation. Now what you see missing is the CDK4/6 inhibitor with a hormonal therapy. I've had some success getting it approved through insurance, but sometimes insurance won't approve something that's not on this list. So that can be challenging, even if we believe it works. And certainly, I think as we learn more and more about some of these other strategies that I mentioned in the trials that are happening and things like that, more will be added. But I think for now, this is what is, when someone says this is what is in the guidelines or the NCCN guidelines or the compendium, this is what they're referring to. And so this is what is currently listed for low grade. So I'd like to end there, but just say, I think hopefully I've shown that low grade is a really different disease than high grade. It does have thank goodness, has a longer survival and has quite a few different treatment options that have really, I think the field has really changed in the last 10 to 15 years. And I think it's important that given this sort of long period of time prior to recurrence, or the potential for a long period of time prior to recurrence, it's, as others have said, it's really important as best you can to live fully sort of between those monitoring visits. Recurrence is common, unfortunately, but there are a lot of options now. I think there's a lot of hope to be had for this disease. I think ask questions, stay engaged in treatment decisions with your doctor. The things that I listed may not make sense for you, and every person is unique and their cancer is unique. So, certainly stay engaged with your doctor and ask about what may be right for you. Quality of life is very important because, you do have a longer likelihood of survival. So you want to make sure that what you're getting is not making you miserable and doing what you want it to do. And I think it's our job to continue the research that's ongoing and continuing to identify some of these targets that hopefully are more tolerable and will continue to produce sort of some of these longer lasting responses. So thank you, and Hopefully that wasn't too repetitive, but I'd be happy to take any questions. That's a good question. Not that I'm aware of that have moved forward, but I think that is a good thought, but not that I'm sort of aware of that are happening. Oh, sorry. Are there any studies that are looking at MEC combined with AI? Yeah.
I know you're talking about recurrence, but I have a quick question on
Yeah.
the initial diagnosis.
Of course.
Is chemo still kind of the standard of care? Because I talked to my wife and two other
Yeah.
people who were just diagnosed within the year,
Yeah.
and none of them had chemo, just went straight to the
Yeah.
endocrine hormone therapy.
Yeah, so that's a good question. So it is technically still the standard of care, which is why I listed it there. I think many of us believe that in our experience and in what we've seen, that we suspect that the study that's happening right now will show that the letrozole monotherapy is not inferior. It's an inferiority study, so it's just supposed to show that it's not worse than chemotherapy and certainly a lot more tolerable. And I think most of us have treated patients that have done well with letrozole alone. And I just counsel patients that while this is, chemotherapy is standard of care, but we have that study open, so I encourage patients to go on that. But I think it's reasonable, and I have patients who have opted not to do chemotherapy too with proper counseling. So yes, it's considered standard of care, but I think, yeah, and I didn't get into it, but the rationale for that big phase 3 study that's enrolling that I mentioned was a study done at Hopkins where they looked at patients who had their upfront surgery followed by monotherapy. It wasn't compared to anything, but those patients did very well, and so it's a very reasonable strategy. Yeah.
I have a follow-up.
Yeah.
So I've noticed that several clinical trials require chemotherapy as a prerequisite for enrolling. So if this other trial that we've been doing for the last 5 years shows letrozole to not be inferior, would future clinical trials maybe change that prereq?
I suspect it will, and I think any that are still enrolling at that point would probably need to change their eligibility.
Okay,
is my suspicion. It would have to be reevaluated. Yeah.
Is there anything we can do to help move that needle to get chemotherapy off off the trial requirements? I've done a ton of it, so it's just for people who
Not at the
haven't.
moment, but I think it's an FDA thing. Unfortunately, for approval for the new drugs, we have to kind of follow that. But I agree with you. I think hopefully as time passes and we learn the results of this upcoming study, and hopefully we're right in what we suspect, I think in the next couple of years, hopefully that'll change.
Do we have any other questions? We are getting to lunchtime, so. Okay, over here.
Do we usually see people getting shrinkage with MEK inhibitors, or is it more stability? Are you seeing people get to NED? I feel like it's usually stability, but
It's a comment. So the 26% is partial response and more. So I've had a patient that's had quite a impressive response on it. I think I would say in my own practice, it's about what is listed. So partial response is probably about that 20%. But I do know patients that have progressed on it. So I think it's not the be all end all, but I think it's a strategy, certainly. And I think, that's why we're so excited, I think, about the Veristem study, or the avutametinib and defactinib, because it kind of takes that strategy but amps it up, and maybe adds something that makes it more responsive. But yeah.
And would you see it as would you see it as a drug that you'd stay on forever, or is there at some point, are you in it enough with the MEK inhibitor studies enough to say that if they got down to NED, would they be able to go off it? I think I know one woman who had extensive time on. She had nothing, and she didn't know whether she should stay on it.
Yeah.
The doctor wasn't sure because they were in charge
That's
of territory.
definitely, yeah, that's a hard question. And I think that's true with a lot of the drugs that we give that are targeted. Most of the trials that are done are sort of designed for until progression. And then we see sort of how people tolerate it over time. I think that's very much a sort of patient-doctor decision together. I think it's very reasonable to stay on something that somebody's tolerating and is providing benefit. There may be a point at which someone says, I've been on this for years and I want to come off and I've had no evidence of disease. And I think, that's a shared decision between the doctor and the provider, the doctor and the patient. But I think that's hard to. Yeah, but I've had patients that have been on it for a long time. Yeah, sure.
Have there been many cases where you have someone on one study, and they had progression, and then they drop that study and hop on another one?
Yeah, absolutely. Yeah. Especially because our studies are involving sort of such specific targets, and we're learning more and more about why people respond and why they may not. And so, I've had patients in all disease sites who start on one thing, it's not quite the right thing, it doesn't work as well, and they switch to something and it works. So I think there's always hope that the next target may be helpful. So yeah, I've definitely had that happen.
My question is, do they ever at any point consider like a second debulking surgery? And how much time needs to pass from the first to the second?
So there's not a kind of cut and dry time point. I think when it has been really soon from your last sort of finishing treatment, or you've progressed pretty quickly after the last treatment that you had, I know a lot of us are a little more hesitant to do a surgery because we think, really what you need is to get on a treatment that works better. The last thing I would want is to do a big surgery, put you at risk of whatever that means, whether that's multiple bowel resections, risk of all the things that can come from that, and complications of surgery, if what you really need is just a better medical therapy that can treat that disease. But that being said, we do certainly do secondary cytoreductive surgeries for low grade. And there are a lot of times when it does make sense, and it's been a long time, and the disease has been kind of hanging out for a while, or relatively minimal, and then starts to grow quite a while after the last time you received something. It's relatively isolated, and I think in those scenarios it does make sense, but it very much depends on where it is, what would have to be involved in removing it, and whether the patient's willing to take on whatever those things mean. Does it mean, something like an ostomy bag? I mean, hopefully not, but that can happen, right? And so I think that's all very patient dependent, but it is definitely considered in a number of situations. If that was dodgy enough for you.
How many targeted therapy we have for low grade?
How many, sorry, what?
Targeted therapy.
How many targeted therapies? I don't know if I can answer the exact number. I think, I think a lot of I showed what sort of is out now in terms of what's NCCN guideline approved, but I think there's a lot being investigated, and probably not that I can count. I know Dr. Grisham mentioned sort of the pan-tumor type studies that maybe you're a low-grade patient, but you have a very specific mutation that may not be normally seen in ovarian cancer, and you could join a trial in a phase 1 group that is sort of across tumors. It doesn't require you just to be ovarian cancer, but you have this particular mutation. So I think not all targeted therapies necessarily have to be just for low-grade serous ovarian cancer. They may just target whatever you have, which is then hard to quantify.
I have a question.
Yeah.
Right here. Right in the middle.
Oh, sorry, in the line. Yeah.
No, that's okay. Does participation in, or I guess I have not participated in any clinical trials at the time or right now, but does any participation in one prohibit you from participation in another? I saw one question was, if you go off of one clinical, can you join another? But is there the opposite, where because you've done this, now you're not eligible for X, Y, and Z?
It depends on what it is. So, for example, if you're doing a trial that involves a CDK4/6 inhibitor with letrozole, like if you had been on the 3026 study, Dr. Slomovitz's study, that required no prior CDK4/6 inhibitor. So it kind of depends on what you're trying to do. There's some studies that say you can't have had prior X, or they have a limited number of prior lines, whether that's on trial or off trial. So things like that are usually considered, but just the matter of being on a study doesn't necessarily prevent you from being on another one.
Do you think that that's something, or sitting down with your doctor and looking at all of the studies and maybe mapping out a progression of which clinical trials to go for first? I mean,
Yeah.
is that something, do you feel
Yeah,
like
so
most
I do
doctors
that.
are doing?
Yeah, I
or-
do that because if there are studies that require 2 prior lines, for example, and this is just very general, then you don't want to wait on that one, and then it also depends if that study makes sense, right? You're not just trying to do a study to do one, but if there's one that you think makes sense and there's a limited number that you can have had, maybe you want to think about that one sooner. Again, it depends on the situation, but yeah, I do think about order.
Thank you.
Yeah, but I don't think I emphasized this. I put it in red, but I didn't say it. There is no defined order for recurrent disease as to what patients should get. On that list of NCCN guideline recurrent regimens, there's not, you should have trametinib and then try chemo again and then try X. That there's not sort of a defined roadmap. They haven't been sort of directly compared in a way that tells us that, but so that is very much sort of patient doctor driven.
Okay, great. Thank you so much,
Thank
Dr.
you.
Cobb.